Welcome to the Personality Disorders Addictions Conference Call. My name is Dawn, and I will be your operator for today's call. At this time, all participants are in listen-only mode. Later, we will conduct a question-and-answer session. Please note that the conference is being recorded. I will now turn the call over to Carol Saunders. You may begin.
Thank you, Dawn. Good afternoon, everyone. Welcome, as Dawn said, to our latest NIDA CTN web seminar series, Personality Disorders and Addiction. Our presenter today is Thomas Kelly. Dr. Kelly is Associate Professor of Psychiatry at the University of Pittsburgh School of Medicine. We will have time for questions and answers. You'll be able to either call your question in or use the Q&A mode at the top of the screen, and we will try to keep an eye on that. At this point, I'm going to turn it over to Dr. Kelly. Dr. Kelly, please take it away.
Okay, thank you, Carol Ann.
Thank you.
And appreciate everybody calling in for the Personality Disorders and Addiction seminar. Hope to have an informative one. We're going to have a brief review. Well, first we'll talk about what we'll be talking about, which is we're going to be talking first about the prevalence of substance use disorders among patients with personality disorders. And then we'll take some questions and move on to looking at how substance use symptoms interact with personality features and why it places patients at higher risk for relapse generally than other populations. And then finally, and probably most importantly, and I have it kind of more heavily weighted toward looking at evidence-based strategies for reducing risk for relapse among these personality disordered patients, because I'm assuming that most people will be interested in more of the clinical information. And we'll have, as Carol Ann said and Dawn said, we'll have chances for people to ask questions and have a discussion in between these different sections of the presentation. First of all, just as a quick review on the topics at hand, personality is defined as a relatively stable and enduring set of characteristic behavioral and emotional traits. Personalities are stable and enduring and generally are more associated with behavioral traits than what we would consider to be psychiatric symptoms. That's essentially one of the big differences between personality disorders and Axis I conditions that are more state-related, such as major depression. And people may be familiar that DSM classifies personality disorders into clusters. And the first cluster, Cluster A, is often considered a more cognitive-based cluster. The thing about these three conditions, schizoid, schizotypal, and paranoid, schizoid is more of a detachment in social relationships and a disinterest in having interpersonal interactions, actually. Schizotypal has a more cognitive base in the sense that there's more eccentricities of behavior based on cognitions. People with schizotypal disorder have more dissociative kinds of symptoms where they have illusions or misconstrue the circumstances, the things they're observing. Paranoid, obviously, people are with paranoid personality disorder have more of a problem with feeling persecuted or suspicious, otherwise just not interpreting the motives of people around them inappropriately, in the sense that they are always kind of assigning malevolent motives. Cluster B, of course, are the borderline, histrionic, antisocial, and narcissistic. These are the patients who have more impulse-related problems. They certainly have more affective instability. Histrionic patients generally are more novelty-seeking. They're more emotional in general. Narcissistic patients may be less impulsive, but certainly have more of a tendency, like the antisocial, to have a lack of empathy and more, obviously, more concern for themselves to the actual failure to recognize the importance of other people. Cluster C, the dependent, avoidant, obsessive, compulsive, these patients oftentimes, the hallmark of their conditions really has to do with anxiety. With dependent people, they're excessively dependent on others, and they're often clingy and looking for caretaking. Avoidant people, very much like we see as, by the way, in Axis 1, social anxiety disorder, are very much concerned about being negatively judged and are very much concerned about interacting or being around others because of their concern about that. And obsessive-compulsive people are very much concerned with orderliness and perfectionism and actually control, to the point that people with obsessive-compulsive problems certainly have a great deal of problem in functioning and actually getting things done. They tend to spin their wheels a lot. Moving to the next slide, we're going to talk about substance use disorders. And we're going to be talking here primarily, the data we're going to be talking about really lends itself more to the idea of excuse me, not abuse or dependence itself even, but more along the lines of conditions that might be considered any alcohol use disorder or substance use disorder. Even though the DSM classifies these conditions as abuse and dependence or dependence, we'll be talking about primarily about disorders versus not having the disorder. And if we look at the abuse and criteria, again, a very brief review. If you have one of these in a 12-month period, a pattern of substance-related role failure, failing in school, not going to your work, etc., or if you're using them in hazardous situations, driving, of course, is the big one, substance-related legal problems, or doing things that are grounds for arrest, also, or certainly social or interpersonal problems. Any one of these in the 12-month period, if you have a recurrent pattern, generally diagnosticians consider this to be a pattern of at least 3 or 4 that in that 12-month period, that's certainly considered alcohol abuse. Dependence, of course, people, again, are probably familiar. We're looking at 7 different criteria, 3 of which would constitute, in the 12-month period, constitutes dependence. And so we're looking at, a marked increased amount to achieve intoxication. A withdrawal syndrome it's going to be different for the different conditions. But these other things, taking more over a longer period of time, persistent desire to stop or cut down, much time spent obtaining, using, and recovering, important activities given up, such as missing important activities with family, etc., or stopping, your activities and things that used to give you pleasure is one of them, as well as continued use despite knowledge of problems. If you're aware that you have an ulcer and it's aggravated by your alcohol use and continue to drink, that certainly constitutes a symptom for dependence. Okay, so we're going to move on, and we're going to start now by looking at epidemiologic studies, so looking at the prevalence of things. And this is data from the National Comorbidity Study that Ron Kessler essentially heads up. And the one thing that stands out when you look at this slide is that the actual condition that has more related to more prevalence related to abuse or dependence for alcohol is actually not a personality disorder, but it's conduct disorder, which is a disorder of childhood that generally precedes antisocial behavior. And as you can see, that the prevalences are very high. I don't have the odds ratios up here, but I can tell you that certainly that women actually, based on the prevalence of these conditions, are actually more at risk for having abuse or dependence than the men in the survey. Now, I want to talk a little bit here about the different data sets. Now, this is the data set that's part of the National Epidemiologic Survey on Alcohol and Related Conditions It's a very large data set, as you can see, 43,000 plus. The data coming out of this particular study actually is finding very high rates of personality disorders, much higher than others. As you can see here, this particular study found almost 8% of the population has obsessive compulsive personality disorder, as opposed to 1% 1 to 2% in previous studies. Now, the difference in methods may have something to do with this. All these epidemiologic studies are done by lay interviewers who are trained, and as much as they may be trained well in conducting the interview, the fact is that I know myself from having done personality disorders examinations like the International Personality Disorders exam, and actually training people on it, that one of the things that people do is, and it's very hard to do even for clinicians, to understand the pervasiveness or how these kind of patterns are stable across and pervasive across different parts of a person's life. And there is a tendency, I think, just in general in epidemiologic surveys to overdiagnose these things because there's just not an appreciation of whether or not these things actually take place in all aspects of a person's life. At any rate, as you can see, men have much higher lifetime rates of alcohol and drug disorders in this particular survey than women, and that's consistent pretty much across epidemiologic surveys, and also consistent with what we see here and what we'll see as we go on. People with obsessive compulsive disorders are probably, when you account for other things, are probably much less at risk for developing substance use disorders than other personality disorders. Here we have data again from the NESARC study. This is the Compton study from 2007. It's interesting that what they've done in this study, as you can see in the slide, is they've controlled for not only demographic variables, but also for other psychiatric variables. And as you can see, the prevalence, or the odds ratios, for whenever other psychiatric disorders are controlled for, are much lower. And again, what's left is in this particular study, dependent patients were still at risk for a drug use disorder, and antisocial, which is again, and we will see, generally consistent. This is another from the NESARC data set, and this is Debbie Hassan's study from 2011. Very interesting information here, because what she did is she looked at nicotine too, but what I'm talking about primarily today, I restricted to alcohol and cannabis use. But as you can see, particular conditions are very much at risk, and what's very interesting is this is persistence over 3 years. So they had looked at the risk for this, and then they looked at it a second time in the same sample with looking for persistence across 3 years. And as you can see, in this particular data set, borderline is represented, antisocial, and schizotypal comes out with a very high odds ratio for cannabis use disorder. And we're going to talk about that a little bit more as we go through information on self-medication. And again, another study by Debbie Grant using the NESARC data. Again, this is onset at 1 year, and you can see that people with personality disorders, you'll see as you read through, if you read through these epidemiologic surveys, they tend to gravitate more toward drug use than alcohol. Some of them having both, but certainly drug use being more common. And if you look at these data, you see that some of the highest odds ratios, again, schizotypal was very high, 10.2, 13.8 for dependent patients, essentially meaning, just so we're clear on this, essentially meaning that if you have a dependent personality disorder, you're almost 14 times more likely to develop a drug use disorder. than patients without it, people without that. So that's very high risk, as well as with schizotypal. The thing that's interesting is, in this study, Grant also controlled in the analyses at one point for the effect of other psychiatric disorders. And when she did that, I don't have the data up here, but these other conditions like dependent personality disorder, schizotypal was still in there, but these other ones that with higher risks like avoidant, they dropped out. And what that seems to indicate, we'll talk about it more in depth, I think, but what that seems to indicate is that the real risk for developing these conditions really has to do with the cluster B class, essentially in the sense that they are the class of personality conditions that have the hallmarks are impulsivity, affective dysregulation, tendency, again, toward novelty-seeking, risk-taking, the antisocial, of course, being impulsive and having no regard for themselves as well as others. And it's those kinds of traits that seem to be associated more with developing substance use disorders. This is another study by Grant, and this is particularly for borderline disorder. One thing that I wanted to show in this slide that I thought was really important, and this is consistent with even the neo-Freudian thoughts on cluster B disorders. If you read people like Otto Kernberg, who was probably the first premier clinician who wrote about and treated borderline personality disorder, these conditions in cluster B are very fluid, and you can see that in this, the prevalence of borderline disorder with other cluster B disorders was almost 50%, suggesting that these conditions sort of trade off symptoms. There are things that certainly are related to narcissistic disorder, antisocial, and histrionic that can also be somewhat associated, certainly, with the symptoms of borderline personality disorder. This is another, this is from the WHO study. This is a 13-nation study with a sample size of 21,000 plus. The USA participated in this. And this, again, looking at cluster A, B, and C. And this particular data set, they used a subsample of items from the International Personality Disorders Examination, and they found, again, that cluster B was very high for developing SUDs, substance use disorders, and this is across nations. And this Lenzenweger study uses essentially the same method for diagnosing personality disorders. They used they used the National Comorbidity Study, the sample, and they looked at developing alcohol and drug use disorders in these different clusters of personality disorders. And as you can see, cluster B comes out very much higher than the rest. And I'll go back for a moment so we can show this. 14.5 here for cluster B. Down here it's 10.3, 8.7, and on the odds ratio. So you can see that that was pretty much consistent using the same method for diagnosis, even though it was a completely different data set. That's a very important finding here, I think. The last thing, I think this is going to be our last look at different kinds of conditions that are associated with substance use disorders. And again, this is data from using the National Comorbidity Sample. And that sample, by the way, had 15-year-old kids in it. 15 to 54 was their age range. And so they were able to look at oppositional defiant disorder, conduct disorder, ADHD, these disorders of childhood. And as you can see, they looked at this particular study looked at risk for developing these conditions over a 10-year span. The first time that they had used the sample was in 1992-93. They conducted this study in 2001 or 2, I think, and then they looked at the development of these conditions over that 10-year span. And you can see that these conditions of childhood actually had higher odds ratios for developing, mostly for drug dependence, than even antisocial personality disorder. And again, it's very telling in the sense that of what comes first, the primary condition, and what we're looking at here are problems in childhood with impulsivity and dysregulation of behavior, essentially. Ron Kessler notes that there's a strong association between externalizing disorders and substance use, and of course it's even stronger in clinical samples, and that most non-substance-related disorders onset prior to the onset of substance-related disorders. That's found almost across studies, that you have the onset of non-substance-related conditions first. The one thing that is important to look at is how pervasive a personality disorder has in having a profound effect on functioning, including feeling symptoms and these kinds of things that lead to drug use. So based on the review, the risk of substance use disorders among personality disorders varies with diagnostic methods, as we talked about. It seems to be higher in cluster B patients, as we had talked about, and actually when you account for, like some of these studies did, for other axis 1 conditions, the odds ratios, the risk goes down, although it still stays pretty high in the cluster B group of disorders, personality disorders. And we really need to integrate these epidemiologic findings with our clinical experience. Again, the effect of the personality disorder and the particular type of personality disorder, the cluster B, seems to have a very strong effect on the developing of substance use disorders. So that ends the first section. We can turn it over to Dawn if there are questions.
Thank you. We will now begin the question and answer session. If you do have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or hash key. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you do have a question, please press star then 1 on your touch-tone phone. At this time, I'm showing no audio questions.
Okay. So I suppose we can move on, and if there are questions related, obviously, to the first part of the presentation, we can take them in the next section. What causes increased risk? The major issues here have to do with what develops increased risk for developing SUDs, and are there other additional risks for relapse during recovery? And we're going to take those things kind of separately here. The primary ways risk for onset increases are through psychiatric symptoms, and again, as we talked about, most epidemiologic surveys, clinical studies also show the same thing, that generally we're looking at the onset of non-substance-related conditions being first, and so that opens the door for whether or not people need to self-medicate or to try to decrease their symptoms by the use of illicit drugs. Illicit drugs, by the way, meaning not only street drugs, but also drugs that are prescribed but are used in ways that are not consistent with the prescriber's recommendations. Now, and the other thing, number 2, of course, the second primary way is genetic loading. We know there's a strong familial kind of transmission of genetic risk, as well as, of course, the developmental environmental factors that we all deal with or hear about when we talk to patients about these things. And when you have an interaction of the first 2, as that increases, of course, then the risk goes up. Now, it's commonly considered a natural response if people become dysphoric, dysphoria meaning, not just depression, but also just a general downshift in mood or downward in mood. And for example, if you look at borderline patients and you talk to borderline patients, they will often not describe. They may have a syndrome of major depression, but many times what they describe are these rapid shifts in mood downward, from moving from normal mood to sadness, anger, frustration that they really cannot explain. And these rapid shifts, because of the nature of them, patients will often talk about a tendency to want to use drugs to feel better. There's an indirect comment on the validity of a self-medication hypothesis, and this is found by Willens, who does a lot of studies of ADHD kids, and he found over 4 years that ADHD patients who were treated had a lower rate of substance use disorder. What that tells us is that if you treat impulsivity, which is the hallmark of ADHD, you have less likelihood of people developing substance use disorder. The other thing that's kind of an associated finding is that many times kids with ADHD will not abuse stimulants. They may have a tendency to abuse other things, but they don't abuse stimulants in general. And this finding just, again, kind of shows that if you treat symptoms and you treat them properly, you actually decrease the risk for developing substance use disorder. And the other thing is, if we look at the issue of impulsivity, you can see how it is so pervasive with antisocial patients who are impulsive generally because of a failure to plan ahead and simply wanting to be able they're unable to delay gratification, simply gratify themselves in the moment, and that's where their impulsivity comes from. Histrionic patients are suggestible and have a need for excitement, and borderline patients tend to act impulsively due to this affective instability that we had talked about. Much of that is caused by interpersonal chaos, where they have a great deal of problems in their interpersonal lives. And so one important observation is that symptoms of non-substance-related disorders onset prior to the substance use, and that this impulsivity and affective dysregulation, emotional instability that come earlier causes then people to want to try to medicate themselves in order to, one way or the other, to either feel better or to somehow regulate their behavior. And if, again, I just have there recall Swenson, if we remember back to the 10 minutes ago when we were talking about how they found the onset of substance use disorders in these young people, I think it was the 15 to 24 age category, when they had a history of ADHD conduct disorder and oppositional defiant disorder, it validates what we're talking about here. Now, some epidemiologic studies have found increased risk with others. We did see where dependent personality disorders in the Compton study was high. The other thing that we had talked about was the schizotypal, the finding of Hassan and Grant related to schizotypal personality disorder, and especially Hassan's et al.'s finding of the gravitation toward cannabis. They're not as robust as found in cluster B, but they make sense because avoidant and dependent people, for example, can be highly anxious and possibly lead to the use of drugs. So Hassan's finding on cannabis is of particular interest, and the reason that is that if you as you read the clinical studies nowadays, what we're finding is that there is an association between the use of cannabis to correct an imbalance in the endocannabinoid system. Patients with schizophrenia gravitate toward 3 drugs primarily, and those are alcohol, cannabis, and cocaine. Now, and I really don't have a good understanding of the cocaine, but I certainly do understand the alcohol and certainly the cannabis. So it may be that patients with schizotypal personality disorder gravitate toward use of cannabis for similar reasons, because they're trying to find a way to help themselves deal with this, the way they're feeling based on this imbalance in their endocannabinoid system. The problem with cannabis is, and I don't know, certainly I was in California recently doing a presentation, and I talked to some people out there, and the problem is that when you try to use cannabis for treating psychiatric disorder and you don't control it well, that the dosages become very much way out of whack, and people use much more than they should. In fact, some research has shown that cannabis can be an effective antidepressant and an effective anti-anxiety agent. The problem is that it needs to be used in small doses, and that's where people get into problems using cannabis. So if we look at self-medication on mood for disorders among men, actually men are have a greater tendency to want to use drugs for self-medication. And this is a study by Bolton, again using the NESARC data set, and you can see the odds ratios here. Dependent, these are people who identify themselves as using drugs to try to feel better. You can see the dependent personality disorders use 8.7. There is a very high odds ratio for developing drug and alcohol problems. It's not as there's some, and although the odds ratios aren't as high for the alcohol side, when it comes to both drugs and alcohol, these odds ratios for some of these conditions are pretty high, and at least among the men. Now you'll see similar findings in the sense that these are significant at the O5 level, but they, among women, the odds ratios are much lower. One thing that I'll say, just kind of a parenthetic sort of observation here, is this note down here is incorrect. This was not adjusted for demographic and other lifetime SUDs, because actually it was the SUDs who are the outcome variables. So that was a mistake on my part in putting that on there. Now, self-medication for anxiety is highly prevalent. Robinson did her study, again, using the NESARC data, and you can see that these odds ratios are very high, almost 11 for use of opioids, and a 20-fold risk for developing substance use disorder among people trying to use tranquilizers to relieve anxiety. And of course, we know just how addictive benzodiazepines are. So, and the other thing is that, again, I don't have the data shown here, but in this study, of course, our subject is personality disorders, and she did look at that. And it's interesting that the higher risk, the higher odds ratios are among the dependent, the avoidant, and the paranoid personality disorders, not in the cluster B range. That goes to show that anxiety disorders, that anxiety associated with these other kinds of conditions can still put people at risk for developing substance use disorders. And what they're showing, of course, is that as people become more comorbid, as their conditions worsen, and especially in these patients with personality disorders, there's an increasing inability to cope and to tolerate negative affect. And of course, if you talk to clinicians who work with patients with addiction, they will tell you, of course, or people on the phone, I'm sure, will know themselves, that one of the things that is the biggest challenge in addiction treatment is to helping patients to be able to tolerate negative affect without needing to or feeling the need to medicate it away or somehow take it away. Now, these other things we talked about in terms of environmental risk, one of the things that's probably one of the most telling kind of studies I've seen recently, I included it here to talk about this, is this study of college students. There were about 400 of them, and the investigators looked at the quality of parental bonds, including care, rejection, overprotection, and how that impacted alcohol use. And women, with their findings were that women with a caring mother were less likely to have antisocial tendencies. And and on the other hand, that feeling neglected or rejected by parents was linked to pathological reasons for drinking and alcohol-related problems. So you can see a clear split there. Feeling neglected by fathers was linked to alcohol-related problems in men, so there was kind of a differential here in terms of same genders, parents having their relationships with their same-sex child having a very significant impact on whether or not they were drinking or having alcohol-related problems. And the other thing they found was that antisocial personality disorder mediated the relationship between being rejected by mothers and overprotected by fathers and alcohol use. So what that means, of course, is that when this was for the men, by the way, that whenever they were rejected by mothers or overprotected by their fathers, they tended to develop antisocial kinds of behaviors, these impulsive kinds of behaviors, disruptive behaviors we talked about, that then contributed to their alcohol use. Now, Ken Kendler's research shows that overall that there's and these are studies done with twins to try to determine the overall effect of genetics versus environment, and that there's a genetic environment split of about 40-60, with the higher number being on the environment side in terms of a risk for developing SUD, and for the personality disorders, and a 50-50 split for the substance use disorders. Shared environmental experience is influential because in the sense that genetic heritage, in the sense that environment is more dominant early on, and we'll see why in a minute here, but later in life, genetic heritability becomes dominant in contributing to conditions, and we'll see why as we talk about this. It's probably related to a shift from what's called a passive gene-environment correlation to active gene correlation later in adolescence. All that means is that environment and experience are not independent in early adolescence because they're related to parental influence. Parents are influencing whether or not kids get into trouble, their environment, they're supervising them more, etc. But in late adolescence, as inherited factors such as temperament are given greater expression due to choice, then kids make different choices that unfortunately are not in their best interest. And this is how these conditions tend to develop, and how the gender or how the environment genetic risk factors interact. Now, Kendler's research using the data has added some clarification, and actually this is a very interesting study. All the references are at the back of this if you're interested in reading further about this. But that ASPD, or antisocial personality conduct disorder, when they do what's called a factor analysis, so they look at how these different behavioral traits cluster together, load together, as they say, the factor loadings are for ASPD, conduct disorder, and AUD are very strong, with SUD between 0.66 and 0.95, with 1 being perfect. So you can see that these are very high factor loadings. Interestingly, borderline personality, even though it wasn't included in this particular factor cluster in the Kendler study, still loaded very strongly with this at 0.35, which is a pretty high loading. Environmental loadings have ASPD, SUD, and conduct disorder at 58, 59, and 40. So you can see that these are genetic loadings, these are environmental loadings, and you can see how these things are consistent. These different conditions and traits are consistent both genetically and in terms of the environment. And now the one thing, this is very interesting and should be very interesting for clinicians. Kendler finds that the liability for antisocial is associated actually with 2 dimensions of genetic risk. One is a disinhibition factor, where people are very novelty-seeking and are vulnerable to depression at a younger age. Another involves an aggressive disregard factor that is more consistent with what we understand as antisocial personality. And there's conduct disorder, heavy alcohol use, and this may be associated with low educational status because these people tend to be impulsive and they have a hard time finishing school. But it might relate to findings that some patients, and this is recent, early writings on trying to treat patients with ASPD in psychotherapy were very, very negative in the sense that clinicians or theorists didn't even suggest that it be tried because the assumption was that people with antisocial personality would simply lie and, in that sense, sabotage the treatment. But we know now that we do see people with antisocial traits who also can become depressed, and that's what's interesting about this finding in Kendler's study, and that actually that people with antisocial tendency who have the capability actually of becoming depressed have actually some fairly good outcomes in psychotherapy. So it's not as it's not as nihilistic, therapeutically nihilistic as it used to be in terms of treating patients with ASPD. Now, we've been talking about risks for developing SUDs, for developing the SUDs. Now, what about risk for relapse? Well, of course, one of the big things, and the 12-step therapies, Bill who wrote the Blue Book for AA in 1935 recognized the people, places, and things, and indicated that what we need to do is change lifestyle so that these things don't happen, and in that way you control your risk for relapse. And again, the impulsivity, novelty-seeking, and affective dysregulation, these are exacerbated by changes in the neurotransmission related to substance use. Point is that drugs like opioids, alcohol, cannabis, stimulants, they cause depletion in serotonin and dopamine, and these changes then contribute to impulsivity and mood changes, and the withdrawal and drug cravings that go along with these kinds of things, of course, make it even worse. So the risk for development of personality disorders and substance use disorders are genetic and environmental, with the genetic influences being somewhat stronger later in life. Risk is high for the development of personality disorders and SUD among those with childhood disruptive disorders. The environmental and development experiences like trauma and neglect heighten risk. And risk for relapse into SUD among people with personality disorders is increased due to environment and lifestyle and the neurological changes brought on by substance abuse. So those two conditions actually interact to place people at even greater risk. So that concludes the second part of our discussion of the presentation based on looking at risk factors for relapse. We can take questions now or have a discussion about this if there are any.
Once again, if you do have a question, please press star then 1 on your touch-tone phone. We have a question from Steven Spirenborg. Please go ahead.
Okay.
Good afternoon.
Hi.
You mentioned earlier in the Weiland study that continued treatment of ADHD led to lowered substance abuse. Was that specific to any type of treatment?
Actually, to be honest, I'm not sure that I can answer that. I know that what they looked at treatment that included treatment with medications, and the findings were related to decreases in impulsivity. And of course, ADHD is primarily treated with stimulants. I have to go back to the paper to really be able to answer that more definitively.
Well, thanks very much.
Sure.
Thank you. Our next question comes from Mary Ellen Eichel. Please go ahead.
Hi, this is Mary Ellen from CTN.
Hi, how you doing?
Hi. I was reading Teresa Winhusen's paper on frontal systems deficits.
Yes.
And the scale that she used to measure frontal lobe, basically, function had 3 parts: apathy, disinhibition, and frontal lobe dysfunction. And I'm wondering how disinhibition fits with personality disorder and frontal lobe function, and if it's a general description rather than a specific characteristic of frontal lobe function.
Well, I mean, it's a good question. The assumption, of course, is that the frontal lobes are responsible for executive functioning, meaning that as we work with people in therapy and even cognitive therapy and other therapies that rely on patients reviewing their behaviors and making different decisions, is based on their ability to to reconsider, to take time, look at, review, and change their thoughts, and that's all really dependent on their ability to on the frontal lobes, because that's where executive functioning such as that takes place.
So when you speak of disinhibition in the personality disorder, that's again a description of a compendium of symptoms or
yes. And again, and as we talked about earlier, it's kind of high-marked in the cluster B conditions, because these are the conditions that most have the tendency to be disinhibited and to act on impulse. And so it sort of kind of very clearly implies that these are the traits, or these are the conditions that we need to try to attempt to affect in treatment.
Thanks.
At this time, I'm showing no further questions.
Okay. Okay, so we can move on to the last part of the presentation, which is on treatment. And as I said, we actually have more on this, but we're going to talk, primarily about some of the things associated with the intensity of treatment, as well as then the kinds of treatments that are effective. When we plan for treatment for patients, hopefully we'll have a discussion about this toward the end. I know when I see patients, they almost never want to do as much as I think they should when it comes to the amount of treatment that they should be getting. Point is that higher levels of comorbidity, and certainly with personality disorders, require more treatment and more types of treatments. We published a paper in Addictive Behaviors earlier this year, a review paper, where it was very clear from reviewing the evidence that the more comorbid patients are, the more severe they are, essentially, the more that we need to combine these kinds of treatments. One of the things that we know is that most comorbid patients and patients with personality disorders, if they have any severity of substance use disorder, can't be treated successfully by seeing them once weekly. They really need additional treatments. And in general, intensity of treatment should probably be based on the patient's place in recovery. This is similar to what's commonly referred to as stage of change, in the sense, and Dennis Donovan and his colleagues in one of their papers on the combined study simply pointed out that what makes sense is to keep people in treatment, but to vary the degree or the amount of treatment that they're getting with where they're at, so that in fact, if there are people who are stable in their recovery, and if you look, maintaining themselves all of the stage of change, then maybe seeing them once a week, once every couple of weeks might make sense. But certainly, when patients are displaying significant signs of problems with substance use and with psychiatric symptoms that can be related to personality disorder, they need to be seen more often. Certainly, patients who have just completed detoxification need to be placed in high-intensity treatments. Residential treatment is often indicated if patients don't have high motivation or a high degree of social support. Partial hospitalization is probably the minimum for patients, comorbid patients coming out of detoxification with substance use dependence. And the other thing that we don't want to lose sight of is that partial hospitalization and residential treatment, inpatient treatments, are very important for people, not only for their substance use, but for the kinds of things that may lead them to relapse once they've been detoxified and in their early recovery. And so those are the kinds of things that dual disordered treatments, especially partial hospitalization, these high-intensity treatments, actually affect, so that you reduce the risk for the psychiatric condition to contribute to relapse into substance use. We're going to talk about 5 models today that have the most evidence for being effective, and that's motivational interviewing, CBT, dialectical behavior therapy, 12-step facilitation, and contingency management. One thing I just added a note down here, one of the things that we don't often think about, but we should, is that if we are able to get case management services for people where we have, whether it's a clinician themselves or a case manager spending time with patients, helping them with being able to find tangible resources, or even spending time with them, that they're more likely to agree to become involved in treatment. And this Haven study was interesting. They showed that if they spent, case managers who spent, I think it was like 30 minutes with patients with antisocial personality disorder, the ASPD patients were much more likely to enter treatment than if they were simply given an appointment and there wasn't time spent in working with them. We did a similar study. Dennis Staley, our director here, did a similar study a few years ago looking at this on our inpatient unit, where if you do a half-hour to 45-minute MI session, motivational interviewing session with a patient, you increase the chances of them following through with their outpatient treatment by at least 2 or 3-fold. So it's very important that we pay attention to these, what seem like small things, but are very important to fold into treatment. The one thing I'll talk about here on harm reduction is that, we're talking about risk for relapse, so we're talking about patients who are not using drugs and trying to help them to stay that way, to stay in recovery. But many patients do not want to pursue abstinence, and so we find ourselves using harm reduction a lot, which is necessary for us to do with them. But it is borne out in research that in one recent study, this Merton study, they did a 10-year follow-up with patients who were at the end of the first stage of treatment, were using drugs but were considered non-problem users. And they looked at people who stayed in treatment, and they compared the, quote, non-problem users with the abstainers, and at the end of 10 years, 75% of the non-problem users had relapsed into heavy use, whereas 48% of the abstainers. So you can see there's a big difference that way. Bottom line being that the more that patients pursue abstinence, the more likely that they are to stay well. The one thing that I should point out, the bottom arrow here indicates that there's an objective approach to working with people who decide not to pursue abstinence. And we know through motivational interviewing and these other kinds of models that where we use empathy, DBT does this to essentially validate a patient's experience. When people don't want to pursue abstinence, the best thing to do is to not try to convince them that they should. The best approach in treatment is to accept it, but at the same time give them objective information, like the point right above, that It's hard to do this. It's hard to control drinking. It's hard to control drug use, and that if you choose abstinence, you're going to be essentially better off. Not to say that you won't work with them if they don't want to do that, but the more that you give them objective information on the realities of these things, the more, the better it is for them in possibly at some point in the future deciding to try to become abstinent. Now, MI, and people may know this, I'm going over or maybe reviewing this for people, but it's basically a patient-centered therapy with a focus on helping people resolve ambivalence. These are the ORs, what MI therapists call ORs, open-ended questions, affirmations, reflective listening, and self-determination. This is the primary way that patients explore with a therapist and for themselves the things that may be leading them to use substances, and for them then to make decisions about how they might change that. It's the best model of treatment early in therapy, and it's because it doesn't assume that patients want to discuss drug use. I direct the adolescent clinic here, and I can tell you, of course, that all the patients I see come in to see me telling me that they don't have a drug problem and that drugs are fine and doesn't hurt them, etc. And so I have to be able to work with them in ways where we don't treat their drug use as a problem, and MI allows us to do that. It's a style of relating, it decreases resistance, and it helps to establish a therapeutic alliance. One difference between MI, CBT, and 12-step in the Project Match was that patients with MI worked better with angrier patients. It's interesting that Kendler's study, the one we had looked at earlier, reported on BPD having a negative factor loading for agreeableness, essentially saying that patients with borderline disorders come into treatment or have a tendency toward being disagreeable. Well, if that's the case, then we need to use these kinds of models to work with them. CBT works best with patients when they've made progress, and once they indicate they want to stop, it's not the therapy. It's therapies like they replace thoughts or cravings. CBT works to replace thoughts or cravings. And it might even, and when it comes to cravings, CBT is very good at helping people use distraction techniques that focus on shifting away from internal stimuli, simply focusing on things around. You can tell patients that are interested in working in ridding themselves of cravings that if they simply describe their surroundings, pay attention to the things outside themselves, they, like counting cars, taking a walk, even though these might be, quote, kind of mindless activities, they take the focus off the craving. The one thing that is interesting, of course, is that in the 12-step therapy or in the 12-step philosophy, the idea is that if you have a craving, what do? You go to a meeting. You call your sponsor. You go have coffee. You do something to take yourself outside that internal process. And that's really what how CBT can be helpful. When it comes to actually preparing, not just dealing with cravings, but preparing patients for maintaining their ability to stay away from drugs in certain kinds of situations, that requires thought changing. And I can give an example here of a patient that I saw who had a very strong dependent personality, actually, but she also had a very bad opioid habit, and she had a tendency to want to use drugs whenever she was in situations where people either invited her to use or she was at a party or whatever. And we worked, but she was also very motivated, and we worked on her changing her automatic thoughts from thoughts like, well, everybody else is having a good time, so I want to have a good time, to her automatic thought being that if I give in to using drugs, I'm going to undo all the benefits that I have made in my life thus far. She was a young mother. She was trying to keep her child, being threatened with loss of her child. These kinds of when people are highly motivated, these kinds of models will work well. Now, DBT, or dialectical behavior therapy, even more than CBT, capitalizes and does it very well for people with personality disorders, capitalizes on helping them change their thoughts. One of the things that DBT does, of course, is, again, in an attempt to validate the patient and to help the patient become more aware of their worth and their value. They want them to lead healthier lifestyles. And the overarching message in DBT is that it's a harmful behavior and it detracts from the quality of life. But like MI and relapse prevention, and unlike 12-step, it recognizes self-determination. DBT therapists are fine with people not wanting to be abstinent but controlling their use, but also recognizes that there is a low percentage of patients with personality disorders, borderline specifically, who can successfully control substance use. So we're back to the issue of looking at abstinence. This particular chapter by McMain in the book referenced at the end is an excellent chapter for understanding how DBT works with substance-abusing patients. One of the things they do, and this is similar to 12-step treatment, 12-step treatment focuses on staying sober one day at a time. DBT works with patients to help them to look at what they individually and specifically might be able to do to what length of time, for example, that they feel that they can handle in being sober, and then helps them to try to achieve that. Well, the other thing, and this is important, this is similar to some of the writings of Alan Marlott, that even lapses, if you look at the glass being half full, in DBT, even lapses can be helpful for providing insights on how to improve chances for staying abstinent longer. And so they advocate doing relapse reviews similar to Marlott, in the sense of understanding the things that can go different in the future. They use the dialectic of the clean mind with the addict mind, which is the synthesis of that is the clear mind. And the one thing that again, as I said, that DBT does very well is using mindfulness and self-management. Again, in managing cravings, they advocate what might be considered urge surfing. For people who may not be familiar, urge surfing is simply a term, and again, I think it was Marlott that used this term, but urge surfing is really a way of helping people to kind of desensitize themselves to cravings, that as you get cravings and as you have thoughts and feelings that you want to use, to simply sit with it and consider it and recognize that at the same time that it happens, it doesn't mean that you have to act on it. And so what it does is it essentially helps people to desensitize themselves to the effect of cravings, and DBT encourages that kind of a model. One of the things that DBT does that's very helpful is that they create cognitions to help patients control their impulses. And one of the things that they talk about doing, which is similar to other kinds of techniques that are used in DBT, is that they don't try to change the fact that people have a craving. For example, patients might learn to target their addiction when they have a craving for, say, a drug. DBT therapists help patients identify other things, such as a warm bath or a nap or something that is in the healthier range, but also can be craved, and helps them to see that as an object of craving and change their cravings for drugs to these other healthier kinds of activities. It's a very creative and can be a very helpful way of helping people self-soothe, as it says there at the bottom, whenever they have a high level of motivation for controlling their drug use. Now, it's important, just and maybe you're seeing as we're talking about this, that it's important to recognize that CBT and DBT they actually were modeled or created for helping patients with other kinds of problems, not addiction. So it's more these kinds of things that we can take from them, the kinds of techniques and the kinds of approaches that they advocate that really is helpful in working with patients with addiction. Even McMain and the chapter that we talked about here, that Marshall Linehan is an author, talks about the fact that people who are DBT therapists who come to treat patients who are primarily substance abusers find that they're harder to form a therapeutic alliance with. And that's true, and again, that's why we go back to the MI, to the motivational interviewing kind of model that we talked about earlier and how well it helps. 12-step facilitation can be used as a standalone therapy. It's an adjunctive therapy where the content related to 12-step treatment is included in other kinds of treatments. It emphasizes the 12-step philosophy, going to meetings, getting a sponsor, working the steps, and the treatment includes actively supporting patients meeting people in NA and AA and getting to meetings. So essentially it's trying to get people involved in the activities. Now, we used one in our clinical trial that we were part of here. It was the CTN 31, where we used it with people who had stimulant addiction, and we included 5 group therapy sessions, 3 individual sessions, and these all focused on various aspects of 12-step activities, and we simply replaced some of the partial hospitalization treatment that people would get as treatment as usual by supplementing it with these, or supplanting these sessions. And it was found that the preliminary evidence finds that it's effective for increasing attendance at 12-step meetings. It wasn't as clear that the patients in the 12-step arm actually had less drug use. On the other hand, it's important to recognize that the studies that are being done nowadays may not be able to determine just how effective completely they are, because we can't follow patients nearly as long as we'd like to most of the time because the costs are too high. But it is clear that, and the one thing that's important to recognize is that clinical research across the board finds that 12-step therapy, or that people going to 12-step treatments, 12-step activities, improves their chances of staying abstinent and staying in recovery infinitesimally. That's the best word I can say. It's probably the best thing going, actually, for patients, even over and above the formal treatment that we give them, because it provides so much for them that formal treatment can't. Okay. The last, actually, model we're going to talk about is contingency management, and it's clearly an adjunctive treatment, but it's very effective for treating addiction. For people who may not be familiar, contingency management is simply pairing a target behavior with an incentive to get people to follow through with the behavior that we'd like to see them display, such as coming to treatment, coming to their meetings clean, providing clean urines, those kinds of things. It's very effective with methadone maintenance, targeting patients to come to counseling sessions and remain abstinent from illicit drugs. And of course, many patients with personality disorders are in these particular kinds of clinics. And the other thing is that it's effective at reducing addictive behaviors among patients with PD, as effective as among those who don't have personality disorders. One particular study looked at lowering psychosocial impairment among patients with antisocial personality disorder being treated in a methadone program, and found that contingency management was effective at doing these things. Weinstock found reduced treatment dropout among severe patients with SUD and a psychiatric disorder who were in contingency management compared to TAU. And the one thing, I thought this was a very interesting study. It's 2003, so it's not actually a very new study, but they compared patients with antisocial personality disorder on cocaine use who were treated with cognitive behavioral therapy versus CM, and found that there was a reduced use among people with the CM condition, greater, statistically significant than the people in the CBT. So it shows that CM, contingency management, some people have problems philosophically with it. There's issues sometimes in implementing it, but when you do it and you do it right, it works. We use CM in our partial hospitalization program. This is a study that I directed. We're still working on getting the paper published. Everything, so much seems to get in the way of getting this published because everything else seems to be more important. But we provided incentives in a graduating fashion to simply to try to get more consistent attendance at our partial hospitalization program. And it certainly worked. People who were in the CM part of our program but the partial hospitalization came in more consistently, and we did collect some clinical data that showed that increased attendance was associated with decreased psychiatric symptoms and stress. Now we'll talk briefly here about medications. This is a relatively new area of research, but at least when it comes in terms of looking at it for personality disorders. But antipsychotics, aripiprazole and olanzapine, for people who aren't clear, this is Abilify, this is Zyprexa, and mood stabilizers other than Depakote are best for BPD, depression, and anger. And you can see these studies that I cited here. You can look at those. Giannoli suggests that these medications may reduce cravings. The one thing that we find, and this was in the paper that Dennis Daly and Antoine Touahy and I published earlier this year, is that medications that are prescribed for non-substance-related conditions, what I mean there is that drugs like these novel antipsychotics and antidepressants don't necessarily seem to help that much in actually reducing drug or alcohol use. But with patients with BPD, these things, it makes a lot of sense because, as I said earlier, patients with borderline disorder are quite impulsive. They have a tendency to act very quickly on cravings, and if you can reduce these things, again, it's a new field, or it's a newer field of study, but it can be very important for helping people stay in recovery, people with borderline disorder certainly. And again, Zyprexa was found more effective against anger and aggression than SSRI antidepressants or even benzodiazepines whenever heroin-dependent patients were treated with them. Now, there's little research in the area of looking at substance use among PD patients where the medications are designed to reduce the use of the drugs. The one thing that I found that I cited here is that Velsky and others looked at antabuse and naltrexone and found that they were as effective for patients with personality disorders with alcohol use disorder as patients with axis 1. So, and some of the other things that we talked about earlier seems to indicate that patients that personality disorder doesn't necessarily negate the effectiveness or make it such that the patients with these kinds of traits are less responsive to these kinds of medications. So the conclusions here are patients with personality disorder and SUD require highly structured treatments. They should consist of psychotherapy, behavioral interventions, and pharmacotherapies, the more you do counseling, the more you do things like contingency management, the more that you give people medications after, a good understanding of the patient themselves and the likelihood of the effectiveness, the more that you combine these treatments, the more likely it is that patients are going to stay in recovery. And again, whether you use it as part of the treatment or not, encouraging involvement in 12-step treatment is very important for these patients. And again, treatment intensity can be reduced with stability in recovery. We want to honor people's goals. Again, if they don't want to pursue abstinence and they do want to pursue controlled use, that's their decision, and we want to continue to work with them. But we want to also give them the information that helps them to understand that that's a very hard thing for patients with an addiction to do. Again, we're back to this, the issue, if you subscribe to it, that addiction is a chronic relapsing disease, and you need to pay attention to the chronicity of it. MI is the best psychotherapeutic approach for addiction, especially early in treatment, because you need to establish a therapeutic alliance. And it should be used as a style of relating throughout treatment. CBT and DBT techniques are quite helpful when people are motivated to control substance use, and 12-step therapy is very effective and should be used certainly with patients who want to pursue abstinence. Contingency management, the reason it works well, it does work well, is that, the one thing that's important to look at is that behavioral therapies like this, they don't require insight. People don't have to necessarily agree with you as a therapist or agree with your principles or philosophies or any of that other stuff. There's an incentive that they want. They don't have to develop insight for it to work. And that's one of the values of contingency management as an adjunctive treatment. Okay, well, that concludes the third portion, the last portion. So if there are any questions on any of the subjects we discussed, we'll be glad to take them.
Once again, if you do have a question, please press star, then 1 on your touch-tone phone. We have James Mayer in line with a question. Please go ahead.
Mm-hmm. Hello? Didn't hear anybody.
James, please go ahead.
Can you hear me now?
Yes. We can hear you.
Thanks. Was the actual cost of the things provided in the contingency management study that you did related to the improved outcome or in the attendance and such? Or is it simply the offering of something that was related to it?
Actually, I think it was both. The way we did it with the fishbowl system, and if you're familiar, this is where people have a chance to earn a prize of some sort. The prizes in the, actually were on the large continuum, everything from a bag of potato chips or a candy bar up to $25 gift certificates. So people had a chance to win any of those kinds of things, and they seemed to respond well to the whole idea. Actually, just to talk about this a little bit, one of the things that seemed to be, and it happens with these kinds of programs, is these people in the groups, they became very interested in seeing, taking their chances to win and in seeing others. There was actually a section of the last day of the partial group on Friday afternoons that they saved the last half an hour or 40 minutes so that they could participate in this. It literally became kind of like a party. They called it Fishbowl Friday. So there's sort of an air of, there's a desire to win, and there's also, this camaraderie that goes along with it.
A follow-up question.
Sure.
You had mentioned about the changes in the brain as a result of abusing substances, and that psychopharmacology is helpful with that during the healing process. I read some studies that the brain actually repairs itself through cognitive behavioral therapy or through psychotherapy. So I was wondering if you have, in fact, if you have any information on that, and how long would it take, if there is any, research, and how long would it take for the brain to heal once it's in recovery and treated with these medications and treatment that we are describing?
Well, it's a very good question. Actually, I'm aware there's actually some work done on looking at what's assumed to be the curative effects of psychotherapy. In fact, if patients just stop using drugs, that along with time will repair itself. There's a very interesting set of slides on the NIDA website, the National Institute on Drug Abuse, and they'll show you brain images of patients who just come out of recovery, and then 2 years later, and it shows that they compare their brains and the brain imaging through these PET studies to a normal brain. And if you look at these, the slides are very revealing. The brain for people who have just come out of recovery and are addicted, I think the one in particular was somebody who was addicted to stimulants, and they showed his brain, and it was very dark, and essentially the difference it shows up in how much is lit up and the colors that come out. And in the temporal lobe area, in most of the areas, it was very dull compared to the control brain. But the same person 2 years later, they showed his brain, and it is essentially normal as compared to somebody who hasn't been using stimulants. So yes, in fact, the brain repairs itself. And I think my assumption, and based on what I've read and seen, is that if you stop using for 18 to 24 months, you essentially get back to normal. It really has to do with the regeneration of the receptor sites for these different neurotransmitters.
Thank you.
Okay.
Once again, if you do have a question, please press star then 1 on your touch-tone phone. At this time, I'm showing no further questions.
Okay.
Do you have any additional comments?
No, not at the moment. I would recommend that people take a look at the reference list and see if there's things that they want to, look at further. Nothing more from me at this point, though.
Thank you both, Dawn and Dr. Kelly, and thank you to all our participants for a great discussion. We would like to remind you to take the survey that will come in your email after the webinar is over. We appreciate your comments, and it gives us an opportunity to tweak things and do better. The recording and slides on Shifted will be placed on LiveLink as soon as we have them available for your review. Again, thank you very much for participating today. Thank you, Dr. Kelly.
Thank you.
And good afternoon, everyone.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.